Thank you all for joining today's town hall. We are very excited to have an excellent speaker with you all here today. First, we'll do a little bit of housekeeping details. I'm Shannon Malloy, CureJM's Director of Community Engagement, and we are very pleased to have the esteemed Dr. Susan Shenoi here with us today. We will hand it over to her in just a minute, but first, a quick reminder, we are making a recording of today's session, so if you do not wish to be recorded, please keep your screen off and your microphone muted. We are going to take questions throughout the session as well as at the end. So go ahead and put your questions in the chat, and we will read those questions to make sure that they are heard by everyone watching the recording. After Dr. Shenoi's presentation, we will have a brief update on upcoming events, and we will break into breakout rooms for some conversation with other families so you can have a chance to meet other people who've been down this road of dealing with juvenile myositis as well. So with that, it's my distinct honor to introduce Dr. Susan Shenoi here with us today. She is a highly regarded pediatric rheumatologist and associate professor in the Division of Rheumatology at the Department of Pediatrics at Seattle Children's Hospital. She's also the clinical director for the Division of Rheumatology and the director of Seattle CureJM Myositis Center of Excellence. Oh, Joel, welcome. Dr. Shenoi is well known across the country for her patient-centered approach and her research in improving outcomes and treatment approaches for all pediatric rheumatic diseases. Her work emphasizes the multidisciplinary care and the importance of individualized treatment plans for her patients. So we are very pleased to have her with us today talking about second-line treatments for juvenile myositis. So Dr. Shenoi, over to you.
Thank you so much for that kind introduction, and thank you to everybody who's tuned in to listen in to this talk. So I am going to share my slides here. Okay, can everybody see the slides? Just the single slide?
We see two slides.
You see two slides. Okay.
But I think it's probably okay. There
How
we
about
go.
this?
There.
Okay. All right. This just means I'm looking to the right because my screen is to the right. So I was tasked with talking about second-line treatments in juvenile myositis. And today is an important day in our nation's history. And if anybody here understands the electoral college system, kudos to you, because to me it seems like a maze that needs to be navigated. And sometimes I think it can feel similarly when you're navigating the medical system for your child with juvenile myositis. So the path seems complex and seems really nuanced. So I'll try to shed some light on what we as physicians think when we are managing your children. So my goals for today really are to hope that you learn and understand some really key concepts around the field of juvenile myositis. We're going to talk about second-line treatments in juvenile myositis, and then I'm going to do an overview of side effects. I always say my goal is accomplished if I actually don't get through my slide deck. So I want to make sure everybody's question is answered. So feel free to interrupt, unmute. I actually cannot see anybody, so I wouldn't be able to see hands raised or anything like that. So just feel free to interrupt, unmute, and ask your questions. And then at the end of the talk, I would request that y'all give me your feedback because that is how I improve these talks. So let's dive straight into key concepts in the field of myositis. So we call it juvenile myositis when it happens in children. And sometimes you'll hear the term idiopathic inflammatory myopathies, which also is sort of an umbrella term that encompasses all the different kinds of autoimmune or inflammatory myositis. Sometimes you'll see people divide that based on what is seen in the child. So either skin involvement, when we call it juvenile dermatomyositis, where dermato means skin. So you can see some of the classic rashes. Juvenile polymyositis, or JPM, when there's muscle inflammation but no associated skin inflammation. And then sometimes you'll see this term called overlap myositis. That means there is presence of myositis with other diseases such as lupus or scleroderma. More recently, in the last several decades, people have started classifying juvenile myositis based on the autoantibodies that are present. So either MI2 positive, TIF1 positive, NXP2 positive, etc. So what are autoantibodies? Well, autoantibodies were discovered a while ago, and you can see the top graph here shows the timeline. And there's more and more autoantibodies that are being discovered every several years. The best way that I can describe autoantibodies are, think of the pizza base, right, which is your dough. That is your myositis. And then depending on what toppings you put in, whether pepperoni or olives or ham or prosciutto, whatever you have it, that gives you a different flavor to the pizza. So same way, an autoantibody is a topping. You still have the base of myositis and muscle inflammation, but the presence of, say, TIF1 gamma would give you more sun sensitivity and more skin features. Similarly, the presence of anti-NXP2 antibodies would increase your risk for calcinosis. So the presence of an autoantibody in myositis will give you a different flavor to your disease. Why does that matter? We're starting to learn more and more about autoantibodies, and we're recognizing that they may actually be pathogenic, which means they may be causal for the disease. And they also give your treating doctor a clue of what the risk factors are in your particular child. So most patients should really have an autoantibody tested at some point during their disease course. So let's go back to sort of basics. What causes myositis? We actually don't know. We know that there's pro-immunogenic and anti-immunogenic factors. So think of it as a balance scale. And this balance scale is tipped more sort of in the direction of pro-immunogenic factors, where your body is having a lot of inflammation. That's a simplistic version. So when you look at the immune system, it is highly complex. Our immune system consists of several differentiated cells, such as B cells, macrophages, T cells that are over here. And each of these cells produces certain molecules that are known as chemokines or cytokines. These are little tiny protein molecules. And these molecules then engage with different cell surface receptors and then cause activation of cells and sort of immune dysregulation. So oftentimes you'll hear us talk about cytokines, which are these overactive molecules. And cytokines can be pro-inflammatory or anti-inflammatory. So again, when the balance tips into more pro-inflammatory cytokines, that's when you'll see more inflammation present. So how do we treat juvenile myositis? There's two big, broad categories of medications. One is immunosuppressive medications. So that means to kind of damp that overactive immune system, you suppress the immune system with immunosuppressive medications. The other group of medications are known as immunomodulators. A good example of this is IVIG. So IVIG is not hugely immunosuppressive, but when given in large doses, it helps modulate that immune function. Another term you'll hear us talk about is DMARD. So DMARD stands for disease-modifying anti-rheumatic drug. And there's several categories of DMARDs. So there's conventional synthetic DMARDs, which are the traditional sort of pill medications such as MMF, etc. There's the newer medications that have been now around for 20 plus years, which is known as the biologic DMARDs. And sort of the newest molecule is the targeted synthetic DMARDs, which are synthetic tiny little agents that you can use orally, known as JAK inhibitors. More recently, in the last 3 to 5 years, I would say, you can also hear physicians or your providers talk about biosimilars versus biologic medications. So the best analogy I can give for that is think of snowflakes. So no two snowflakes are alike. So a biologic molecule is the originator molecule. It was the original molecule that a company developed and then did trials on. So for example, for adalimumab, the original molecule was Humira. It was known as Humira. And then over time, once the patent sort of gets done, each of these companies have patents for several years, and when the patent expires, then several other companies get into the game and they create similar molecules. So, for example, now we don't only just have Humira, but in the last 2 or 3 years, we've got at least 10 or 12 other Humira-like molecules. So they're very similar to the original molecule, but they have a few nuanced differences between them. For your child's treatment purposes, it doesn't matter whether they're on a biologic or a biosimilar, they both act the same way. And studies have shown, more so in Europe than here, that these drugs essentially treat diseases the same way and they have similar side effect profiles. So let's look at the treatment paradigm for juvenile dermatomyositis. So our first line of therapies is usually a combination of one of these medications. So prednisone, which is steroids, methotrexate, IV steroids that are sometimes called pulse methylprednisolone doses, and IVIG or intravenous gamma globulin. It's important to note that none of these therapies are actually FDA approved in pediatrics. From a very old trial done in Europe, there's a group called the Printo group. This was a study in 2016 that showed in patients with juvenile myositis, the addition of methotrexate actually seemed to help rather than just giving the patients steroids alone for their myositis or giving them prednisone and cyclosporin. In adults with myositis, the FDA actually approved IVIG in 2021, and this was known as the ProDerm study. We in pediatrics have been using medications off label for a really long period of time, and we know that many of these medications work really well. Other adjunctive first line therapies, so an adjunctive therapy is something that helps in the treatment, include hydroxychloroquine, also known as Plaquenil, physical therapy, sun protection measures, topical steroids or topical tacrolimus, and then addition of calcium and vitamin D, particularly when the patients are on steroids. After this first line of therapies, then we have various second and third line therapies, and here sort of people will differ in what they choose. There isn't any great science to this, and what I'm going to do today is I'm going to talk about some of the more recent therapies. So in the interest of time, I'm not going to go over each and every one of these, but I'm going to talk about some of the biologic agents that are circled here, and then I'm also going to talk about the JAK inhibitors. So let's look at the different therapies and the timeline of development. So this is a really nice picture from this particular journal. And you can see in the old ages, in the 1930s, we used to treat arthritis and similarly myositis with things like gold salts, sulfasalazine, azathioprine, cyclosporin. And I've circled all the different medicines that we used to use when there weren't biologics available, and we still use these medicines to date. And these are more the conventional synthetic DMARD. So you can see these are all relatively older medications as compared to the biologics, which the first one was etanercept, and this was developed in 1998, and then a whole host of other agents were developed, including the JAK inhibitors. So when we say biologic agent, what do we mean? Biologic agents are considered targeted therapy. That means instead of the conventional synthetic DMARDs that kind of broadly immunosuppress your system, the biologic agents target one particular molecule that is active in inflammation. So for example, like I said, our immune system is complex. We have B cells, we have T cells, we have dendritic cells, macrophages. A biologic agent would target one particular system. So for example, rituximab here targets the B cells, etc. Or they would target one particular cytokine. For example, we have TNF inhibitors or IL-6 inhibitors. So here's a pro tip. Most biologic agents are engineered, so they are large molecules. They're usually not available as pills because they're too large to be taken as a pill. They're usually available either IV or subcutaneously. Most biologic molecules would end with either MAB, which stands for monoclonal antibody, such as adalimumab or Humira, or they end in CEPT, which means they are a receptor blocker agent. So let's look at rituximab. How does rituximab work? Rituximab blocks one particular compartment of your immune system known as the B cells. In particular, it blocks the CD20 B cells. So there's many different types of sort of B cell stages. It is usually given as an intravenous infusion. That means you would get admitted either to the hospital or an infusion clinic, and you would receive an IV with the medication over a couple hours. Usually to start out with, it is given as 2 doses 2 weeks apart. However, there are many different regimens available. Some people will give it weekly for 4 doses, and other people will give just a single dose. And then most would start to monitor for symptom return or return of the CD20 cells. There is a blood test that we can do to look at the CD19, CD20 cells. And then they would decide on redosing rituximab every 4 to 8 months as needed. As I mentioned, there are several other biosimilars now that are available for rituximab. So I've put in my slide the names of all the different biosimilars available because it can get really confusing as to which medication is which. So what data do we have for rituximab? The best data that we have is from a few years ago. This study was published in 2013, and it's known as the RIM trial. It stands for rituximab in myositis trial. This trial actually included not just adult patients with dermatomyositis and polymyositis, but also included pediatric patients with juvenile dermatomyositis. They had a large number of patients enter the trial, as you can see here, 200 patients, and they studied rituximab in the form of 2 regimens. So rituximab was either given early at week 0, or rituximab was given later at week 8. And usually when we study trials, we look for randomized control studies. That means the likelihood on getting on rituximab or dummy medication, which is known as placebo, is 50-50. So that's sort of our gold standard in terms of what we want to see. So this study, rituximab in myositis trial, showed that there was actually no difference between adult and juvenile myositis, and didn't meet its primary endpoint, but about 83% of patients showed some response, which tells us that rituximab actually works. After the trial was done, the investigators did what we call post hoc analysis. So they looked at all the data and they tried to make sense of some of the data. And what they found that patients that had autoantibodies, such as in the red and the purple line here, these were patients that had MI2 antibodies and Jo1 antibodies. Patients that had autoantibodies actually responded much quicker and better compared to patients that did not have autoantibodies, as shown in the green line. So one of the things you may hear your provider say is, well, if you have autoantibodies present, that tells me you're more likely to respond to rituximab, and that may favor their treatment choices. Let's look at another biologic agent known as abatacept. It's also called Orencia, which is its trade name. So abatacept works by blocking sort of co-stimulation or engagement of the T cells. And this is given either as an IV infusion, but also can be given subcutaneously. How do we know that abatacept works in children with juvenile myositis? Rodolfo Curiel and Lisa Ryder's group published a study, which was a small study of 10 patients with juvenile myositis. In this particular graph here, each different colored line actually represents a different patient. And they looked at abatacept in these patients with refractory juvenile myositis. Most of the patients in this study had disease duration of over 2.5 years. And they found, so if these lines are going up, that means the patient is improving with time over abatacept. So you can see here, almost everybody except this one particular child improved with abatacept. And about 40% of patients were able to reduce their prednisone dose. And overall, abatacept was really well tolerated. So most children did not have huge side effects. Moving on to another biologic agent, so TNF inhibitors. TNF stands for tumor necrosis factor, and this is a cytokine molecule that is pro-inflammatory. There are several different TNF inhibitors that are available, and most of these are approved in children with arthritis. For juvenile dermatomyositis, there are three that have been tried. So infliximab, which is an infusion. It's not available as a shot. This is given at 0 to 6 weeks and then repeated every 4 weeks. Etanercept, which is a weekly shot under the skin or subcutaneous molecule. Adalimumab or Humira, which is a shot that's every other week. Sometimes you'll see providers also use this weekly. And these act, like I said, by blocking the TNF molecule. We don't have large studies in children. There are some larger studies in adults, but most data for children comes from case reports or case series, which means people use it in a couple patients and then they write those patients up in the literature saying this medication worked. As I mentioned, there's several new biosimilars now out on the market. So you can see for adalimumab, the originator was Humira, and we have so many different biosimilars that are available now on the market. Moving on to tocilizumab, also known as Actemra. And here are some of the biosimilars that are in development for tocilizumab. Tocilizumab works by blocking a different cytokine molecule known as IL-6. There's a couple other IL-6 inhibitors that are available that I don't believe to date have been used in juvenile myositis, but have been used in pediatric arthritis. Tocilizumab is available as an IV infusion that's given every 2 to 4 weeks, or it can be given as a weekly shot. And similar to the TNF inhibitors, we don't have large studies, but most of the studies are case reports or smaller case series. I'm going to pause there and see if there's any questions from the group. Please unmute and ask questions if you have any, because I can't see the little tiles.
One question that did come in, Dr. Shenoi, I don't know if you can hear me.
Yes.
So you've been mentioning a lot about the autoantibodies, which the parents are very grateful to get such a good explanation of. You've mentioned quite a few times patients who don't have an autoantibody. So does that mean that they don't have juvenile myositis, or it just means that they don't have an antibody that we've discovered yet?
Yeah, I think you answered the question right there. So about 30% of patients are autoantibody negative currently. And what I think that is that that's yet to be discovered. So in my lifetime, as you saw in that graph that I showed, these autoantibodies are being discovered over time. And when I started in rheumatology, there were only a few. I started in 2007, and you can see here how many more autoantibodies have been discovered since in just my lifetime. So even though we say they're autoantibody negative, oftentimes on the autoantibody testing, you will see them report out, there's a band present, we don't know what that band is. And to me, that means there may be an autoantibody waiting to be discovered still. Does that answer the question?
Yeah, it does. It's sometimes a little bit confusing because it seems like maybe autoantibody negative might mean you don't have juvenile myositis, but that's not the case.
That is not the case, no. Okay, what
any
other
other
questions?
questions? I know everybody's muted, so it might take a minute to jump off mute. They might be holding them till the end.
Okay, all right, I will move on. So I'm going to spend maybe half a minute on some of the newer second line treatments known as targeted synthetic DMARDs. And these are newer molecules. They're actually available orally because they're not biologic molecules. These are known as JAK inhibitors, which stands for Janus kinase inhibitors. And think of these sort of more as broadly immunosuppressive again. So JAK has several effects within the cell, and it activates various different components within the cell, as you can see here. And there's many different types of JAK and many different JAK receptors. So we have different JAK inhibitor molecules. I've marked the ones that people have used in juvenile myositis in blue, which is tofacitinib, also known as Xeljanz, and baricitinib, also known as Olumiant. There are other JAK inhibitor molecules that are being used in arthritis and other autoimmune conditions such as ruxolitinib and upadacitinib. Upadacitinib actually just got approved in juvenile arthritis. So it is possible that these other JAK inhibitors eventually may be tried in patients with juvenile myositis as well. So let's get to the meat of this. How do we know? We have so many different options now, which is amazing, right? It's great to have so many options, but how do we know which medicine is right for my child or your child? The bottom line is we actually don't know. So there, we could do cytokine panels, but they're not reliable, and they're not validated. We don't really know which molecule is active in which patient. So unfortunately, right now, the way it is that we do trial and error. Okay. You will often see us use combination therapy. And that is a good thing because while you're using a targeted blocker and you're blocking, let's say, IL-6, you're only blocking that molecule. What if other molecules are active in your little baby? So oftentimes we'll do combination therapy with a conventional synthetic DMARD, such as methotrexate or MMF, known as Cellcept, or a different medication such as Plaquenil. And the reason for doing combination therapy is you have one that is broadly immunosuppressive and then another targeted agent on top. And there's a lot of thinking that goes towards that these two molecules actually work synergistically together. That means they work much stronger together than they would individually. One of our big goals, and one of the things that we do know, is that steroids have lots of long-term side effects. So one of the goals in treatment is get the patient in remission, but also get them down on steroids and off steroids as quickly as we can. And so we use DMARD medications as steroid-sparing medications to allow us to reduce and get patients off steroids. Now, before I logged on, Shannon said a lot of questions that families have is what happens if my child flares? So I added this slide right before I got on. And I put here, ask 5 pediatric rheumatologists how to manage flares, and you may get 6 answers. And really, what I'm trying to say with that is there is no prescribed or protocolized treatment. And just like how autoantibodies give you a different flavor, the course of your disease and how you've responded gives you a unique flavor to how your provider or doctor may treat your child with juvenile myositis. So they may look at things such as what autoantibody does this particular patient have? Which medicines has he or she responded well to in the past? Which medicines do they have the most side effects with? So there are many different factors that go into deciding how to manage one particular flare. And I often joke and say to my families that every time I think I know what I'm doing, you know, the patients prove me wrong, which is to say, we have these preconceived notions in our head that X, Y, or Z is going to work for sure, but the bottom line is we really don't know. Okay, so let's talk a little bit about side effects. And what I did, instead of doing individual side effects for each drug, which can get really boring, I kind of lumped all the side effects together of the BDMARD medications. So the main side effect is that these medicines are immunosuppressive. We want them to be immunosuppressive because that is how they dampen that overactive immune system. But because they're immunosuppressive, these medicines really increase the risk of infection. So being really vigilant about infection. Other side effects including allergic reactions, which are more common with the IV medications such as rituximab and infliximab. The presence of either infusion or local injection site reactions where you can get welts locally when you give the shot or the IV infusion. Decreased cell counts. So the white blood cell count may reduce with some of these medications. The JAK inhibitors can often cause anemia as well. Increased liver enzymes. Some of the medications can you can develop autoantibodies to the medication itself. So these are sometimes known as HACA antibodies, which are commonly seen with infliximab and adalimumab. And then there is a black box warning on these medications, which needs to be taken with a grain of salt, that they can cause malignancy. And the reason for that is when the original studies were done in children with arthritis, um, and older adults, they found that over time, some of the patients developed certain skin cancers or lymphomas. And so, being abundantly cautious, the FDA put in a black box warning of malignancy. That was more than 20 years ago. And since then, there have been several studies, more so in arthritis, but also in dermatomyositis and myositis, showing that these medications probably directly do not cause malignancy. And the patients that got malignancy were those that were likely going to get it anyway. So, what can you do for some of these medication side effects? What can you do to help protect your child? For the infection risk, be really vigilant about fevers. So, any fevers over 101, we usually say go and see your pediatrician, let your rheumatologist know that you have a fever. Tell your pediatrician or the doctor who you're seeing in urgent care that your child is immunosuppressed, because a fever in a healthy child is very different from a fever in an immunosuppressed child. Make sure you're doing things to protect yourself, such as hand washing, good hygiene, getting your yearly flu shot. Check with your rheumatologist on which vaccines your child can get. Usually, if they are on immunomodulating or immunosuppressive therapy, they should avoid live vaccines, but killed vaccines are okay. If you have experienced a true allergic reaction and not an infusion reaction, which is different from a true allergic reaction to one of the IV medications, usually they will stop the medication. Sometimes some centers can do desensitization protocols where they admit you and they give the medicine much more slower. But I'm not sure if everybody has access to desensitization protocols. What happens if you get large welts at the site of your injection site reaction? So these are local injection site reactions, and usually taking an antihistamine such as Zyrtec the day before, the day off, and the day after your shot helps with those. For low counts and increased liver enzymes, those are usually transient or temporary. So this is why we recommend doing regular labs every 4 to 6 months, depending on the medicine, so that we can catch these. And oftentimes we'll either dose reduce the medicine so that you're not getting this, or we'll hold the medicine for a few weeks and then recheck your labs and restart it. In cases of developing antibodies to some of the biologics, oftentimes what we do is we combine it with a conventional synthetic DMARD, such as methotrexate, because studies have shown that if you combine it with another broadly immunosuppressive medication, that kind of confuses your body, and it has a lower tendency to develop autoantibodies. And in terms of malignancy, I would say make sure you're getting regular doctor checkups so that somebody is doing a physical exam on these children at least twice a year to make sure they're not developing big lymph nodes or abnormal findings on their exam. Let's talk about a few of the newer medications that are in development. So we know that in dermatomyositis, interferon is an active molecule and it's sort of inflammatory. So there's a new drug that blocks interferon that was presented at our annual ACR meeting last year by Rohit Agarwal and his group. And this study was in adults, and recognize that first studies happen in adults before they come to kids, but it's very exciting that there is a new anti-interferon beta agent. This is given IV, and you can see here that the patients responded really well, both in terms of skin and muscle inflammation. And then the newest kid on the block, which is kind of an entire immune system reset and is gaining a lot of press, I think, at every meeting and most lectures, etc., is what we call CAR T cell therapy. So CAR T cells are basically cells that are obtained either from the patient directly, so autologous, or from a healthy donor. These immune cells are then sort of engineered through virus transduction or gene editing with a gene known as the chimeric antigen receptor, or CAR gene. This genetically engineered cell then is made to undergo expansion in vitro outside the body, and then reinfused back into the patient after the patient has had a period of some immunosuppressive medications that we call lymphodepletion. What this particular therapy does is it basically kind of resets the entire immune system. It's like ramming the immune system into resetting itself back to baseline. And this has gained a lot of press. The first studies were done, the first patient was described from Germany by George Schett's group, and then subsequently, patients have used it in adults with anti-synthetase syndrome, which is a particular myositis autoantibody seen more commonly in adults. And you can see these adults were older, they were in their 40s, but they had failed many, many medications, including steroids, cyclophosphamide, rituximab, IVIG, baricitinib, leflunomide, tofacitinib. They received that lymphodepletion and then received the intervention, which is a single infusion of the CD19 targeted T cells. And you can see between 150 to 240 days out, all of these patients were completely drug-free, except for one that needed to start a little bit of azathioprine and MMF back again. I didn't put this in here for time, but there was also recently in the last month a little boy from Europe that received CAR T cell with juvenile, very refractory juvenile dermatomyositis that they reported out that did really well as well. So with that, I think there's a lot of hope in the field of juvenile myositis. And I'd like to acknowledge the entire team at Seattle Children's, Lisa Ryder for her mentorship and letting me borrow some of her slides. Our team also includes Christian Lude, who is our scientist, and our physical therapists, Chris and Alex, and Suzanne Edison. And last but not the least, we would not be where we are without the families who are a part of the Center of Excellence at Seattle Children's. And I always say, the incidence of JM is 1 to 4 in a million. So all our families are really 1 in a million. And the Cure JM Foundation for their support of the COE. So many thanks to Shannon and Lauren, who are helping keep track and have invited me over here. And I will take questions. I will leave this on so y'all can give me some feedback.
That was excellent amount of information and a really great overview of some things that we might not always hear every time we go into clinic. So we'll turn it over to all of you to come off mute and ask any questions that you have. We do have a couple questions that also came in by text that we can ask while we're waiting for people to come off mute. So one question that came in, and this is actually I think a little bit more of an art than a science, but we'll go ahead and ask if there's anything that you might be able to add to this conversation, Dr. Shenoi. One of our new families asked, when you are coming down off of the prednisone, how do you know as a clinician which of these treatments to start discussing with your families? And I know that's an art and that's very hard to answer, but is there anything that you might give advice that you might give a new family on what kinds of questions to ask and how doctors make those decisions?
Yeah, so I think that there's a term known as shared decision making, and that's really a critical concept in medicine, which means that particularly in diseases like juvenile myositis, where there isn't the right path, right? There are many paths that still lead to hopefully remission. A lot of it depends on what the family's values are, what the family's preferences are. And really, I see our role as physicians to give you the menu and say, here, at this point, you're still on steroids, you failed X drug, you could do rituximab, you could do abatacept, you could do tocilizumab. These are the risks and benefits of each of these 3 medicines. Now you go home, research it a little more, and then tell me what you want to do. So I think that it's very, very variable. And it really often depends on what the family's values are and preferences are. In terms of what questions are helpful to ask, I think really asking, how is the medicine given? what are the side effects of the medicine? So common sense questions. And is there any newer data to show one medicine works better than the other? There are still many studies being done, and data is constantly evolving. So I think just making sure you're asking the question, is there any new data that needs to be considered in this decision making process?
Excellent. Damaris also has a question, which I think is a very similar question. So as we're talking about second line treatment options, are these new treatment options something that you might consider for a patient who's stable on a current medication, but that medication is pretty disruptive? So for example, IVIG. If a patient is stable on IVIG, but missing school every month or missing work every month is not working for the family, would that be a conversation worth having with the clinician?
The simple answer is yes, because my goal is to really get the disease in remission, but also to let the child and family have as normal a life as they can. Now, I recognize that you're not having a normal life because you have this disease. It's a chronic disease, it's a variable disease. It doesn't tell you when it's going to flare, but you really want to have some semblance of normalcy. So, even if you're stable on certain medications, but you're having a lot of side effects from one of these medicines, you may want to consider switching that medicine out for a different medicine. We see that often with IVIG because it's so disruptive. A lot of the kids get the aseptic meningitis headache, which can be really disrupting. And if that's not working and the child is missing school every month, that's not okay. You should ask about other options. Another time to sort of add on a second line treatment is if you're not able to get off steroids. For me, getting off steroids is the first primary goal. Um, Way back when we didn't have all of these medicines available, somebody started treating myositis with steroids and they realized, wow, steroids work wonders. But over the years, we've realized that steroids can have a lot of side effects in the long run, particularly more for children because of its effects on growth and bone. We want the kids to grow. We want our kids to be tall. We want our kids to have healthy bones in the long term. And so we really want to try and get them off steroids. So if oftentimes I'll say, gosh, you're still on steroids and you're 6 months into your disease. We really need to get another DMARD on board so that we can reduce the amount of steroid exposure for long term. And it can be, I see the question there, IV steroids and or oral, any form of steroids. You really want to try to get them off steroids. The only steroid that I will tolerate is the tiny bit of pre-medication steroids with some of the IV infusions, such as rituximab or IVIG, which is a minuscule dose. But if anybody's getting repeated pulse doses of IV steroids or is on long-term oral steroids, you really want to try and reduce exposure to that by getting on another DMARD medication.
Dr. Shenoi, when you say long-term steroids, do you have a time frame? Is it 9 months? Is it 12, 15? What is your kind of time frame for long-term, or does it vary by
Yeah,
patient?
I would say anything more than 6 to 12 months, and I recognize that's a big window, but anything more than 6 to 12 months makes
Okay.
me uncomfortable. So, in an ideal world, I want to get kids off steroids before the 1 year anniversary of their disease.
And let me ask you a question that came in by email by a mom who's at work, but she's eagerly waiting for this recording. So in their case, what the doctor has suggested is adding in some additional medications while they continue steroids. They're still within that 12-month window that you mentioned. Is that your experience that it's oftentimes a good idea to add medications, even though that might be scary to the parents to be taking now 2 or 3 or 4 different things so that you can reduce the prednisone?
Yes, and that is my practice too. I would say you never want to stop prednisone willy-nilly or abruptly because that often just leads to a rebound, really bad flare. So what I tend to do is I add medications, and when I then get a sense that things are under control, that's when I'll start to slowly taper the steroid medication while they're on combination therapy with other DMARDs.
Right. Yeah, it can be a little confusing for new families that hear about tapering and reducing medications. to then say, wait, why are we adding medications? And I think when you explain it as we're adding medications so we can reduce the prednisone, that makes a
Yeah.
little more sense. Great. Well, these are really good questions. Rachel, yeah, we answered your question. We're talking about any kind of steroid. Although, Rachel, I do know with the IVIG, you will get a pre-treatment of a small amount of steroids. So
Mhm. Yeah.
that's not what we're talking about. Not the
Not
steroids
the
that you have with
pre-medication.
IVIG,
Yes.
unless it's a big pulse of several hundred milligrams. Any other questions? We answered all the ones that came by text. Well, what we can do is Lauren will send out the recording. You've got the form here to give Dr. Shenoi your feedback. And if any other questions come up or pop in as you're able to digest this information, we can get those questions to Dr. Shenoi by email.
It's
This
great.
was a lot of really good information and I think a really good overview of a complicated topic. You did a nice job of making it easy to understand.
Yeah, well, thank you for having me. Hopefully, everybody's voted by now, and I will wait to hear your feedback. Thank you so much.
Thank you, Dr. Shenoi. That was excellent.